Okay, good morning, everybody. It is January 12th, 2023. We have Leo here, our PACU resident, who's going to give a discussion on some ACLS and some cardiac review. So give your undivided attention. Throw things in the chat if you want to, and then let us know if you can't hear. I do have a speaker hooked up here, so we should be able to play videos then. Okay. Hide. Meeting controls. You can kind of swipe that away if you need to as well. All right, take it away.
Yeah, so my name is Leo. I don't know, I think I've met most of you by now, but if you haven't, nice to meet you. So I'll be talking about, ACLS review. I think I heard that everyone was kind of doing BLS and ACLS, and then kind of how this relates to, pop culture a little bit, and commotioCordis is a one way that people can arrest. Specific example is Damar Hamlin that happened about 2 weeks ago now. So let's get started. So like I said, objectives, we're going to talk about ACLS, commotioCordis, a little bit of pathophysiology, epidemiology. Maybe I can tie it into electrocardiograms a little bit as well. So the first thing, essentially what we'll do in a situation like this is do your ABCs. So airway, breathing, circulation, disability, exposure.
You move this like up or out of the way, just because your slide's up there. Like
better?
That's better.
Okay. Yeah, so do they need to be intubated? Can we use an LMA on this patient? Can we assess their airway quick? Is there anything in their mouth that's causing this? Breathing. Are they breathing? We can do that just by observing. We can listen to them, see if they're breathing. We can do capnography. We can get the pulse ox on them. Do they need oxygen? What's their color look like? Circulation. Do they have a pulse? Peripherally and centrally, you can check that. I think if I feel their pulse peripherally, I know they at least have a blood pressure of like 70. So it makes me feel better that they're perfusing, CPR, we should throw the pads on them right away, just in case, because it's just, if they're doing okay now, they could not be doing well in a little bit too. Do we have IV access, pressors, ionotropes? Do we need that stuff? So disability, that's when the neuro exam comes into play and how frequently we need to do that to monitor them. And then also exposure, their temperature, are they flushing? Is this anaphylaxis? Like what's going on exactly? It can give you some clues. So there we go. So I have a little YouTube video here. Let's see if this works. There we go.
Hey, sorry, Mr. Gang.
It's okay.
That's when I realized it's time to finally do the thing we've been talking about for years. So we're making plans for right.
This is the video right here.
Program today.
So assessing the situation, are they breathing?
No, Rose, they are not breathing, and they have no arms or legs.
No, that's not part of it.
Where are they? You know what? If we come across somebody with no arms or legs, do we bother resuscitating them? I mean, what kind of quality of life do we have there?
I would want to live with no legs.
How about no arms?
I know, I thought
Basically how you exist right now, Kevin. You don't do anything.
All right, well, let's get back to it because you're losing them.
You do a hydration station down there.
I know.
Okay, too fast. Everyone, we need to pump at a pace of 100 beats per minute.
Oh, okay, that's hard to keep
What
track.
thing?
How many
What-
is that per hour?
Who do we talk to about that?
I will divide and then count to it.
Right.
Okay, well, a good trick is to pump to the tune of Staying Alive by
Yeah, there we go.
You know that song?
Yes, yes, I do. I love that song. First I was afraid, I was petrified.
No, it's staying alive,
That's it.
staying alive.
You were in the parking lot earlier. That's how I know you.
staying alive, staying alive. Staying alive, staying alive.
Our resident is using the office, the cardiac, like the BLS scene for the beginning of his presentation. I like it. I don't understand. What do you mean? He's got the office playing in the background. Of them doing like the staying alive, like the CPR.
Okay, he's dead. Anyone know what we do next? Anybody? Rose?
I have no idea.
Anyone else?
We bury him.
Wrong. Check for an organ donor card. If he has one, we only have minutes to harvest.
He has no wallet, I check.
He is an organ donor. He is, yeah. Give me some ice in a styrofoam bucket.
Here we go.
Search for the organs. Where's the heart?
I'm not feeling well. I need to sit down.
Are you okay?
Oh my God.
Leave.
Tell me why you had to cut the face off.
I didn't think it was very realistic in the movie. It turns out it's pretty realistic.
Yeah, so that's obviously not the right thing to do, but yeah. So just moving on. So your secondary assessment is good. If they're able to speak to you, this is where this more comes into play, you know, signs, symptoms, allergies, medications, past medical history, last meal, events. I think a good thing that we were taught in med school is a little acronym called LOCATES. It's LOCAAATESS. So it's a lot of things to remember, but it's kind of organized in the fact that, like, if someone has pain, where is it located? When was the onset? The O. The character of the pain. Are there any additional symptoms? Does it make it better? Does it make it worse? When the time of this started, was there any specific environment that you're in? What's the severity of the pain? Have you had this similar pain in the past? So a lot of times when I'm going to assess things, this is what I have initially to get an idea of what's going on, and then I can move on and ask specific things at the same time, like, oh, is the abdominal pain? Do you have diarrhea? Like specific things to organ systems. So I think that's a useful thing to roll through. So the secondary assessment as well, part of that is going to be, why are they arresting if they are arresting, and in this scenario. So this is where our 5 H's and T's come into play. Are they hypovolemic? Do they need resuscitation in that regard? Are they hypoxic? Is this lactic acidosis or some sort of other acidosis causing this? Are they hypokalemic or hyperkalemic, causing the cardiac arrest? Do they need to be warmed, depending on the scenario that they found them in? Other ways that you might see even coming out of the OR too is these tension pneumos. They can cause cardiac arrest too, just from being intubating and having mechanical ventilation. Toxins can cause this. Cardiac tamponade, the heart can't actually get fully filled to cause that full beat. Thrombosis, so like pulmonary emboli, can cause, you know, backup of that blood, strain on the heart, cause you to arrest. And then also, you know, ACS is probably one of the ones that we think about as well. So I think an important part in what they teach as well is just assigning those roles. And every time I've had to do this, it's great because everyone kind of takes a role automatically. And then by the time I think the leader gets there, it's already kind of been assigned. So a lot of times I'm just recording when I get there just to make sure. So I think the leader will probably be, you know, one of the faculty attending anesthesiologists or the resident, depending on who kind of can get there and help. We need someone compressing, like 2 to 3 people, so we can rotate so we don't get fatigued. Get the crash car and get the AED defibrillator hooked up to them. Someone assessing the airway. Do we need to bag them? Do we need orals? What can we do? Should we get a tube in? Stuff like that. And then IV access. We might need additional IV access for resuscitation and additional medications that we have to give centrally. And then again, timing and recording everything to document what we were doing is a very important thing. So, or what we've already tried to, especially when you're rerunning through your H's and T's. So chest compressions, we want limitations to be 10 seconds or less to keep that flow going. in perfusion. We want to get at least 2 centimeters down, and I can kind of talk about that later, how that affects. But anyways, it'll contract the heart then adequately. We want to do 100 to 120 compressions per minute. So we use the song, I think, is a good way to do that. We want to allow complete recoil to allow that blood to fill back into the heart and then compress again, because if we don't allow that blood to come back, then you're not actually having a good stroke volume as well. And then this is very tiring. I've only ever practiced CPR, so I haven't had to do it myself, but I think everyone I've watched do it looks exhausting. So making sure we have enough people to switch in and out as well. And then checking a pulse every so often with the rhythm analysis is very useful as well to decide if we need to keep going a certain way. Can we shock them? Do we need more pressors, ionotropes, etc.? If we have end-tidal CO2 monitoring available, this is great. We can tell then that we're getting some oxygen off, or excuse me, carbon dioxide off as well. It's probably going to be around 10 millimeters mercury at that time, and then if they come back and are able to perfuse themselves, that's going to come up because of all that now anaerobic metabolism creating that CO2 that's coming off now as well. So it could jump up to 30 pretty quick and thereon higher. If the patient has an arterial line, if we can see that they're getting around 20 millimeters of mercury of pressure, that's useful because the coronary perfusion to save that heart tissue is actually your diastolic blood pressure minus your right atrial pressure. So we can get 20, your right atrial pressure is usually around 7, so we're getting 13. And I think ischemia starts below 40. So if we can start to get that diastolic pressure up, we can hopefully save a lot of areas in the heart. So this is our algorithm that I think is handed out. We have our cards with us. I keep mine on me just in case, so I can run through everything if I'm missing something. But essentially, I'm going to move this bar quick. So looking at it, you're going to start CPR, oxygen. You want to check the rhythm if we are able to. Is this VFib, VTAC? Then we can head down this way. We want to get IV access as soon as we can. If we can't get IV access, we'll go to intraosseous access. We'll have the pads hooked up to them. The biphasic defibrillator, we want it at 120 to 200. And I think it says this on the card. So if we're going to do, if it's a monophasic defibrillator, we'll do 360. And then we can allow the monitor to assess the rhythm and is it shockable or not. If it is shockable, we'll give them a shock. If they don't come back from that, that's when we're going to want our inotropes or our pressors. So we're going to give the epinephrine. I think most of you have probably seen I think we carry around the small epis, we call them, which is just to give some people some support, but we actually want the ACLS dose, which is in that brown container that has the full milligram of epinephrine every 3 to 5 minutes. You know, it says consider an advanced airway. I think that can happen throughout this process. It doesn't need to be necessarily at a certain time, because if we're sitting there bagging them and we can't get them back, it's the best way to oxygenate them is to get a tube in them. So again, we'll do that. Shockable. If not, coming back again, we're going to use amiodarone next time to help with any arrhythmias that could be underlying too, and that can help. And we kind of just switch between the two of them going on and reverse through this process. So the first bolus is going to be a larger bolus of amio, and that's our purple container ones that we see. It's 300 milligrams. A normal, like if someone was on the floor, we're going to start them out at 150. So this is a bigger dose to try to get their heart going, and then we'll continue to bolus those amio doses. So I think one of the big arrhythmias that everyone kind of is aware of is VFib here. There's the absence of those normal QRS complexes. There's uncountable deflections. There's no P waves. It's an irregular pattern, which is kind of the basis of that. So now looking at the other side of the chart, when you have asystole or you maybe have some electrical activity that you can see on the monitors, but you have no pulses, this is what we're going to run down. So I think the big thing, like difference between the two pathways when you initially is you always want to start CPR if you can, but you're going to allow the defibrillator to do the defibrillation first. With this, you're going to want to start CPR, give the epi, get that kind of, hopefully by giving epi, you can get the heart squeezing, get the pressor support up, and get that, if there is electrical activity, get them perfusing again by that. If not, then you go down again, shockable rhythm, CPR going in there. I think that's like really the major difference between the two rhythms. So, and this is probably the job of whoever's leading, observing, to say, I see this rhythm, we should do this right away. I see this rhythm, we should start out by doing this right away. This is, a full kind of summary of everything that's there. It's a little bit nicer to look at, I think, but essentially it says the exact same thing. So there are other causes. It's not just, cardiac arrest, VFib. You can come across patients with tachycardia, which happens quite regularly, but you have to assess why. Is this AFib? Is this hypovolemia? Are they bleeding? Is this actually some sort of supraventricular tachyarrhythmia going on, essentially? So the way that you'll be looking at that is, I think the easiest way to decide what you should do in this scenario is this patient hemodynamically unstable? If they are hemodynamically stable, are they showing signs of altered mental status though? Because that just means that they're not getting adequate perfusion. And that's when we're going to, again, want to get those pads on. We're going to want to cardiovert them there. So the cardioversion is going to actually synchronize when you do it to line up with what their beat is so that you don't cause them to go into an alternate arrhythmia, which is essentially like what I'll be talking about later is causes of that, because essentially if you were to shock them in the wrong spot on that T wave, you can cause VFib, you can cause arrest. So, and that's why it does that. And then based on when we're looking at the monitors, if they have a wide QRS, so if it's too long, we can tell where this tachyarrhythmia is coming from. If it's short, that means it's coming through and electrical conduction is normal. So I can tell it's higher up then. If it's long, I think it's coming from the ventricle, because the time that it takes for that charge to get through the ventricle and cause a contraction takes much longer than that conducting system coming from up top where the atria are. Another ones that we see a lot as well is the bradycardia, bradyarrhythmias going from that. Again, I think the easiest thing is to say, is this person or patient hemodynamically unstable? If they are unstable, we need to give them some atropine, ionotropes, try to get them perfusing better. And those unstable ones, they may be close to coding. They may have some underlying ACS as well that's presenting like that. I had this happen to me on the floor where a patient had a heart attack, but it didn't present as them having ST elevations. It presented because he went into complete heart block because he stopped perfusing his AV valve, or his AV node, excuse me. So he just couldn't get those electrical charges down anymore because the tissue had died. So some examples, there's various ones. Just a normal sustained prolonged PR interval is going to be your first degree AV block. Not as concerning. I think a lot of people have that. They have sick sinus syndrome. They live with that. They're just bradycardic at baseline. The next one is going to be that progressive prolonging until you miss the beat due to various reasons, but you can see that PR get longer, drop, get longer, drop, and it'll usually stay in that sort of ratio. Probably you start to get concerned more so when the second degree type 2 block comes in, is when you just intermittently miss a beat because you don't really know why that's happening. Is there something going on there that's, again, ischemia? And then lastly is when those PR don't line up at all anymore. Nothing is being conducted through the heart, and that's complete heart block, and it really isn't sustainable in life. So getting to what we were talking about, or what we had alluded to in like pop culture, some things. So this is going to be CommotioCordis. I had to look up how to pronounce that because I was 100% sure. So Yeah, it's not commodio. Very Latin. So commotio cordis, sudden blunt trauma to the chest. This is first described in the 18th century, but it wasn't really a topic in medicine until more recently when athletes started experiencing this. The other thing is when an athlete collapses on the field, it's not 100% because of a blunt trauma to the chest. Many people have HOCM, the hyperobstructive cardiomyopathy, where your heart is just too big because of genetic deformations that they don't know about until they get that demand ischemia, and they pass out on the field too. So that's, I think, a lot of times when your kids are getting those physicals, it's really important to make sure that they have a normal, like, EKG, heart beating and stuff, to distinguish that. So I think that another differentiation is that if they come in with this chest trauma, but there's no physical changes to the heart, that's commotio cordis. Now, if they come in, they do a big workup and they have structural change to their heart, that's going to be a cardiac contusion causing that. So that's a little bit different. This is just an arrhythmia that's caused by this versus actual structural damage to the heart. And I think we've all probably had these experiences, but I heard a lot of the players say, like, and a lot of medical professionals say in relation to this, that everyone remembers the feeling like this when this happens, because your first time you see it happen, it's extremely scary. And it's like, a lot of times we don't know these people, but we still feel this way, you know what I mean? So this is just kind of a diagram of how your heart sits up against your chest wall. And you can see there's not a lot. If you have enough pressure on your ribs there, it's not a lot to cause that contraction of the heart. So this is a little video of the hit. It's kind of, I don't know. Sorry if it bothers you at all, but you can tell he gets up and it's just,
it's not what any of us want to see, and everybody's around him, and
I think really
he's going to be okay.
Being able to stand is because he had enough.
So we'll take another break
right away
here in Cincinnati.
He stopped having that, hypotension, just lost, back. So
I've been getting paid $1,000 a month, if not more, just from this app on my phone. And I don't know if you can see this, but it's called Audible. Okay, so I'm going to show you right here. I have checked from Audible. This is for $1,100. This one's for $1,100 again. And then this one is $1,200.
So getting into, a little bit of physiology, just so you can kind of understand how the changes in the pathophysiology happens here.
I don't know what's in the chat.
Oh.
Sorry.
Yeah. Oh, she was just, I heard her speaking, but that's okay.
Oh, okay.
So this is a normal cardiac conduction when you're actually conducting through the heart with the changes in the electrolytes. So I think this is a big reason that we get so concerned about potassium, for example, because when they get too much potassium, it causes them to stay in that state where they don't contract as easily, and then that can cause arrest as well. So you get that large influx of sodium at the membrane. Your membrane's going to be negatively charged, and this causes a positive influx. So when you have that positive influx, it causes the contraction and depolarizes the cell. Now, after that, immediately your potassium is going to come in and repolarize the cell, but you have these calcium channels that keep that longer. So that's where you get that longer contraction. And then eventually your potassium overtakes that in phase 3, and then you go back to your baseline. And this is where a lot of these antiarrhythmic drugs work on. They work on the potassium channels, they work on the sodium channels, they work on calcium channels to help prolong the beat, to help prolong the contraction, to shorten the contraction. So this is where a lot of these medications come into play and work on. I thought this was kind of useful to think about as well, is because we have these EKG leads on, and based on when we're looking at EKGs, it correlates as exactly to where these charges are coming from in your heart. So I think the two biggest leads that I think about when I'm looking at the normal EKG that I'm looking at is like this first one going this way and your second lead going down this way, because your charge is going to be positive influx if it follows the negative, so left atrium to right atrium. It's going to be a positive on the EKG. And then again, looking at the 2, it's going to be positive as well. So I know your heart is sitting like this in your chest, right there. So that's how I can see where those positive charges are coming from. So when you think about it in that regard, your sinoatrial node is going to make that P wave. So initially, you're sending a charge directly towards your first and second lead, right? So it's coming up positive. And then as the potassium goes in that area, it's going to go negative. So it's going to bring it back down to baseline. So that's where you get your inflection back down. And again, there's a little pause because it takes a little bit of conduction time to get through your AV node, or else we'd be beating at whatever the sinoatrial node wants us to beat at, which I forgot what it is at baseline, but it can go up to like 200 times per minute. I know that. So it delays it through. And then once the charge again goes through the ventricles, it's again going 1 to 2 positive again. So that's where you get that upward inflection in that R wave. And then when that potassium comes back there, where it's starting to turn red, and you repolarize to bring that back to baseline, that's bringing your R wave back down to normal. And then after that, you have this lag time where you can't actually contract anymore. And that's going to be changing your QTC if you have a normal QRS interval, like what we talked about earlier in the ACLS stuff. So you get that prolongation. Now, yeah, so I think it's just easier to conceptualize that, because a lot of times when you're thinking about why is this PR segment longer, that's actually what you're interpreting by looking at that, you know. And this is just a conduction pathway through the heart. But so for epidemiology, this is my dog and my cat, by the way. They're very pretty. So this happens about 10 to 20 times per year. I think there's increased awareness after the initial NGEM article back in 1995 reporting this. And I think the people that this happens to are who you think of. They're younger individuals related to ball sports. Baseball is a big one, because if they could like take a ball to the chest, you know, I played baseball for 15 years, and they tell you if you can't catch the ball, like when it's coming at you on the ground, you take it to the chest, or if you're a catcher, you take it to the chest to block it, which isn't technically safe for multiple reasons, as you can see. Yeah, so you know, that's just something to think about, I guess, afterwards, now that I'm done with that. But and I think it happens in almost all sports, though. Football, they think that for him, his shoulder went in and caused this contraction of his chest. You can get elbows. Yeah, and I think they've just found it to be higher in males, because males play more of these contact sports. So I think that's where that comes into play. So the clinical presentation, I have some notes here. So I think one article that I looked at specifically on the AHA came out about 10 years ago, that they did this study essentially on pigs to see, and they actually just shot balls at the pig's chest, which is kind of morbid, but to see if they can cause this to happen. They probably just hung them. I don't know. That's from what I gathered. So yeah, so essentially the experiments have shown that under 50 miles an hour, these impacts don't cause cardiac contusion, essentially, and they won't cause any structural damage to the heart, won't fracture ribs, cause bleeding in the heart, stuff like that. And then on top of that, they found that the minimal kind of contraction pressure that's needed is about 30 miles per hour. So there's a sweet spot of 30 to 50 miles per hour as far as objects coming at you are concerned, that can cause this arrhythmia to happen without any structural damage. You know, based on that, there may be some superficial bruising. The VFib's going to kick in and they're going to pass out, like we watched. We already kind of talked about the VFib, but this is the actual studies version of that. They were showing that they caused this on all the leads, essentially. For the pathophysiology of this, now kind of thinking about with those charges and stuff, there's two main mechanisms that cause this that they aren't 100% sure which is the actual phenomenon. So one theory is that the pressure disperses this repolarization, so it prolongs that T wave essentially by stretching your potassium receptors out. And they think that when it happens, they just aren't able to equilibrate, and it causes this fibrillation of contractions because of the changes in the charge caused by that. So they're repolarizing not in synchronous, and so that causes that fibrillation of charge through. And the other theory is an actual depolarization on that T wave that's causing a contraction to, again, cause the desynchronous charge through. And it's essentially a PVC, and it can cause ST elevations that downline are a cause of VFib as well. One thing that I thought was interesting is that, again, looking at it, it took between 200 and 400 millimeters of mercury of pressure to cause these contractions without actually causing the cardiac contusion or not being enough of a contraction to cause the electrical change. So there's a little bit of evidence there to show how it's actually working. And then kind of talking about all this, I think an important thing is like, what do we do after someone arrests? You know, we got them back, but are they neuro intact? Are they able to breathe on their own? You know, they might be perfusing, but they're not able to speak. Did they have a stroke? Stuff like that. And so that's essentially what this chart is running through, is you still need to correct all your H's and T's because they will have abnormalities after this. You want to maintain them on a normal oxygen. You may need additional access depending on what you need to give them for vasopressors. I think it's similar kind of in the fact when we come off cardiac bypass in the OR, we need to do all this stuff to make sure, because your heart went to sleep for an hour or 2 hours and the electrolytes are all changed. So we need to get those out. We need to get the pressors going to cause the heart to beat again and change the currents, and I'll do all that stuff. So it's very similar. There's been some research done on actually causing hypothermia to decrease the metabolic demands of the patient, might be beneficial for them as well. So you might hear people saying, like, should we make them cold? Should we make them cold? Like, I think it's around 32 degrees Celsius is what I remember. Is there actual reperfusion injury now too? Because that can cause, again, arrhythmias, it can cause damage to tissue, all that stuff, stroke-like symptoms. So I think some considerations in the ICU in this setting as well, since we have all the stuff available, is, you know, capnography, blood pressure monitoring. Do we need an arterial line? Do we need continuous tele? We want an EKG. We're going to do serial neuro exams probably every 15 minutes, 5 to 15 minutes. You know, if they're not perfusing, that lactate's going to build up. So we're going to need fluid to correct that and cause this stuff to change as well. Now we're going to need imaging too. And this, you know, with the heart, like for commotio-cordis, for example, the chest x-ray isn't going to show anything. So we might need to look at an echo to see if there's an actual contusion, EKGs, hypotension. If they were passed out for that long, we probably want to see an EEG monitor if they're not responding to us, to see if they have electrical input. You know, are they brain dead now because of this? Just because your heart is beating doesn't mean you're alive up here, right? So and then again, I kind of mentions a few of these things. So eventually all this stuff will be done in the ICU. And I think this is essentially what they're doing afterwards, you know, where they're saying, oh, he's neuro intact, because they're giving them sedation holidays, and oh, he's able to speak with us. Like, they're glad because that means he wasn't, you know, deoxygenated so long that he had a stroke, obviously, and stuff like that. So in summary, these are the two major things. I think takeaways is your ACLS, and then return of spontaneous circulation, just knowing what you do after that. So thanks. So my dog's name is Nako. He just turned 6 this last weekend. He's a full black lab, and then my cat is a cat that we adopted from a barn. He was like 4 weeks old apparently. So yeah, and then that's my fiance, Lindsay. She's also a nurse.
When's the wedding?
September. So we
She right here.
She is actually applying, so she might be around soon. Yeah. She thought about applying down here, so if you guys are hiring, she might like it. Yeah. I'll tell her to apply. So she was a neonatal ICU nurse in North Dakota. So she hasn't worked with adults, but she wants to switch back to adults. So yeah.
Nice presentation.
Thanks.
Yeah.
Does anyone have any
There's
questions?
Anything in the chat, if somebody put it
Oh,
in
yeah.
there. Got it.
I like your dog and cat are friends.
Yeah, my cat beats my dog up actually. So. Harrison. He's named after Harrison Smith on the Vikings. So.
Your Vikings hat.
Yeah, yeah.
Helps me with this topic. I was like, totally an NFL fan.
Yeah.
So, well, good. Thank you so much. Hopefully it's been a good 2 weeks for you.
Yeah, definitely.
We just have a quick announcement from Tonto. Hand hygiene up to 95%. Super happy.
Good job.
And then there's this recharge room. You guys want to check out, it's great. Like a relaxation room. I heard they're giving away money in there.
They're not. They're not.
But maybe
Thanks everybody on Zoom. Serena was just making a few
Different
announcements
location.
about there's a recharge room in UH and then our hand hygiene is
We
back
can
up to
post that.
95%. So good job.
Yeah, it's like everybody's like, nobody knows they're there.
Thank you.
Appreciate it. All right, have a good day, everybody.
I don't know who I need to.